Good morning, dear ladies and gentlemen. First of all, I'd like to express my deepest gratitude to Professor Mohamed Elkasaby for his kind invitation. And secondly, I would like to express my sincerest apologies for not being able to be there with you in person today. I hope you enjoy the presentation and hopefully we can interact during the discussion afterwards. So I'm going to present about EVAR, not only the basics but some tips and tricks to overcome difficult anatomies that you might face when your practice doing EVAR grows. In terms of history, I always like to mention that the Russian scientist Volodus has already published and performed his first EVAR even before Barudi, who's known to be the godfather of EVAR, has published anything in the early 90s. Both of them started with a bare metal stent with the dacron fabric overlying it, mounted with a balloon and inserted into the aorta or the iliac vessel. So it was a very primitive idea that have evolved much now, and this is the case with any invention. In terms of indication, we all know that EVAR is for treatment of not only aortic aneurysms but also for iliac aneurysms, and you can use it for occlusive aortoiliac disease. Although the name will differ, then it won't be EVAR, it will be probably CROP. The other indication, which is probably the most important one, is the treatment of rupture aneurysms, as you could tell from the recent publication from the IMPROVE trial, which has proven superior to open repair. In terms of graft structure, we know that we have fabric and stent. The fabric could be either PTFE or dacron, and the stent could be stainless steel or 19-0, so that's force versus flexibility, as you know. And in terms of graft design, we have either unimodular, bimodular devices, or even trimodular. So this is an example of the unimodular aortoiliac devices. And this is an example of the bimodular, which comes in a main body with one long ipsilateral limb and short contralateral gate with an extension. This is the trimodular new devices with a small main body with two short limbs and then the necessity to extend on both sides. So the benefit of this is the lower profile of their delivery system, and the other benefit is the lower number of stents that you need to keep on shelf for emergency cases. In terms of fixation, EVAR graft systems comes either with infrarenal or suprarenal fixation using barbs and hooks, but also mainly relying on oversizing, except for one graft system, which is the AFix from Endologics. It uses anatomical fixation saddling on the aortic bifurcation. This is how the hooks and the suprarenal stent look like, and this is how the AFix from Endologics look like sitting on the aortic bifurcation. As you can see, you build it from down and you extend up with neck extension. This is very good in cases with a very tight distal bifurcation of the aorta, not able to accommodate other bifurcated devices as in less than 16 millimeters, and also for saccular aortic aneurysms, which you don't have space for opening of the contralateral gate. In terms of prerequisites for EVAR, we all know the guidelines and the instruction for use for proximal and distal landing zones, but it's not a necessity these days if you have to do something to overcome a difficult anatomy. We're going to discuss that in the next few slides. So this is the first example when you come across a very angulated neck like that in a patient who's not fit for open repair, and your only option is an endovascular option. You could do the dress technique for the neck, which is short for design, reconfigure, elongate, stiffen, and straighten. So you insert a couple of super stiff guide wires beside each other, so maybe 3, 4, or 5 even super stiff guide wires to straighten the neck, and then over one of them you can deploy a bare metal stent as the Palmas stent in the neck to make it straight. And also the metal framework will help your fixation with the EVAR graft, as you could see in the angiogram on your right hand side. Very good result at the end.